Thank you. Hi, everybody, and welcome to this conference hosted by MS Focus, the Multiple Sclerosis Foundation. I'm your host, Deborah Foreman, the Educational Programs Coordinator, and I'm joined today by Cherie Binns, who for the next hour is going to attempt to answer all of your MS-related symptom management questions. Now I'd like to introduce her. Cherie Binns is an MS certified registered nurse and is also the patient healthcare liaison for MS Focus. Cherie was diagnosed with relapsing remitting MS in 1994 and has found that adopting some changes to her lifestyle has made her MS much easier to manage. We're very pleased to have her join us today. Cherie, thank you for being with us. And I'm going to turn it over to you and we'll see if we already have some questions. Give me 1 second, though. I want to tell everyone if you've never been with us before and you're not familiar with how to submit your question, all you have to do is go into the app down below and just click on the Q&A button. We are trying to stay away from the chat area. So just submit your questions simply through the Q&A and we'll be good. If you have to ask your question live, if you want to do that rather, you can always just click on raise your hand on that button. And if you're on a phone and you want to do it that way, you can just hit *9 and I'll unmute you. So let's go to the bottom. Let's see. Ooh, they haven't come in yet.
Yeah.
I'm sure they're coming though.
We've got a couple of dozen people that have logged in already, so
Yeah.
get your questions into the Q&A. We have had several questions between Dr. Boster last week and Dr. Conti last night. There were questions being asked in the Facebook stream, the live stream on Facebook, about tolobrutinib and frexalimab or frexalinib, something like that. They're two drugs that are in the pipeline right now. They have not been approved for use yet by the FDA. The tolobrutinib is one of the BTK inhibitors, and it's still potentially 6 months to a year away from being released. So it'll be that long before it will be able to be prescribed. And at this point, it will only be prescribed for non-active secondary progressive MS, where you're not having relapses anymore. The other is an infusion, much like Ocrevus. It's a CD40 rather than a CD20 targeting drug, and it's an every 6 month infusion, or maybe it will be an every month infusion. I forget whether it's the 6 month or the 1 month one, and that's still 2 to 3 years out. So we won't be seeing either of those. And I see a question has popped
Yep.
in. Yeah.
And this person says that they have a UTI presently and have found that when they attempt to speak, they get muscle cramps that make their speech labored and hard to breathe. Is this considered an MS hug?
I don't think so. I have had UTIs pretty frequently in the past on different types of medications that I've been on. And when that happens, what it does is it ramps up my MS symptoms. And so if I'm having trouble with word retrieval or something like that, that gets much worse during a UTI. Cramping or spasticity does too. So I have a feeling it's related to the UTI. And once your antibiotic kicks in, those will just ramp right back down again.
Hmm. Okay.
All right.
Mm, if you have a question, please put it in the Q&A and I'll grab it and tell Cherie. No, I wonder if was there anything that was left out from anything that we didn't get to last time with Dr. Thrower. I don't remember any questions that people had.
One of the things that we did address with Dr. Boster has also been addressed on our private Facebook groups are some new cautionary things about um, the anti-CD20 drugs or the B cell depleter drugs. And that is, we're seeing with older women, meaning those of us who are over 50, that we not only have a higher chance of infection, and we're not talking really bad infections, we're talking more frequent UTIs, as our last person was asking about, maybe more frequent colds or bronchitises, things like that. We tend to have a good 3 to 3.5 year window to take those medicines before we're at a higher risk of these infections. And we're also seeing increasing evidence that when we come off of these medicines, our B cells are no longer activated. So last year they were talking about this phenomenon that they're beginning to see being called a functional cure. So there's another question.
Yep.
I'm wondering if this is the same person that wanted to know if it was the MS hug, wanted me to explain more about the MS hug. The MS hug is spasticity, except that instead of affecting a limb like your arm or your leg, it affects the muscles around the rib cage. And so they get tight, and it almost feels like your ribs are being squeezed. And it's harder to catch a deep breath. I know for me, my MS hug was at this level. So it really felt like I couldn't get a deep breath. It wasn't just the lower rib cage. And the MS hug can be addressed with medications, but I would recommend a couple of things that you might try to do for it before resorting to medication. I've found that cooling, my MS hugs get worse during the summertime. And I find that if I cool with a cooling vest or cold packs around the area of the squeezing, the discomfort, that helps. Also, drinking very quickly a very, very tall, cold drink. So you're this is, I think, a 16-ounce glass. And if I had this full of like slushy ice, putting it in the blender and then just chugging it, talk about headache. But boy, I'll tell you, it takes this away. So I would try those two things. In the winter, there have been a couple of times where I've had to hug and a heating pad actually helps.
Hmm.
So
Thank you. Robin would like to know what you think about the interstem for bladder.
I think it can be very helpful. There is some question. Some MRI companies will not do an MRI on you if you have an interstim in your bladder. So that's something that you may need to take into account. I'd ask your neurologist or the radiologist that's at the MRI center and ask them if that would rule out your having MRIs to track the disease progress. Um, there are some really promising testimonials coming out of people who've had the interstim implanted. So it does seem to help most people that have it inserted.
Thank you. And Elisa would like to know, um, since 2023, she's been diagnosed and recently had an episode for one day, biting like in her hand, which she said she's never experienced it before. And after a day, it disappeared, but her doctor still decided to give her Solomedrol for 3 days. What is your opinion on this? It was it an MS flare or possibly not?
You said biting in her hand?
Um, let's see. But it says biting. Uh, had an episode for one day biting like in my right hand. Now, if she wants to ask the question live, we can do that, but are you able to see what she wrote?
Um, and who was it this that
Um,
wrote it?
Eliza, Eliza.
Eliza.
Yeah.
I
I,
don't see her on my screen.
she says,
Is it from?
I've had MS since 2023, and recently I had an episode for one day biting like in my right hand, which I have never experienced before. And after a day, it disappeared, but my doctor still decided to give me Solmedrol for 3 days. What is your opinion on this? Was it
It
an
was
MS
one
flare?
day worth of symptoms. I I would not have treated it with steroids. So, needle-like. Yeah, you know, these are what we call a paroxysmal symptom, where you have like jabbing pain, like needle-like pain that comes on off and on for a period of time, but the symptoms don't last very long. They won't be there for maybe even more than a few seconds at a time and then resume. And that's paroxysmal, what we call paroxysmal pain or paroxysmal symptoms. And they really don't warrant steroids to treat them.
Hmm,
So I'm sorry that happened. And I can't say it won't happen again. It just may be a symptom that pops in and out.
thank you. In regards to infections that can worsen your symptoms, can those include seasonal allergies or arthritis?
Yep. Seasonal allergies, arthritis, a cold, a urinary tract infection, even a wound that gets infected. So, anything that causes your body to mount an attack against something can worsen your MS symptoms.
Okay, and this person says that a week ago they took a fall outside and hurt both their cheekbone hard and got a few stitches by their eye. I'm sorry to hear that, by the way. Could that make my whole body ache now and make it harder to walk?
Yeah, because when you landed, you jarred everything. Um, there might have even been a whiplash or a bouncing of your head, and that tweaks all of the muscles in your body. So that certainly is something that you can expect 3 to 5 days minimum of achiness from. And
Thank you.
Tylenol or ibuprofen might help that some.
And Jim says that he's on Ocrevus. What is the steroid for? What's the steroid for that they gave him during the infusion? Also, they gave him Benadryl.
Okay, the steroid usually is Solumedrol or IV Solumedrol. That they give before the infusion, and it's to prevent an infusion reaction, which the Benadryl also does. Um, Ocrevus is and Briumvi definitely are pretty rigid about using the steroid as a pre-med. Rituxan, which is very, very similar to both of those meds, has some flexibility in the pre-med, and they allow things like Tylenol and Benadryl, or maybe even um, something to help your stomach, like a Zantac or something like that. And now that Ocrevus has been on the market for a few years, they're relaxing some on that. So if you don't want the steroid and you've been doing well with your infusions, it may be time to have a discussion with your doctor about doing away with the steroid and adding something in like Tylenol or the Zantac, something like that to help with any reaction you might get.
Hmm, that's good. Thank you. Cindy said, what's the difference between spasticity and tremors?
All right, a tremor is like this, and spasticity is a tightening generally. Um, Spasticity can also be like if you're trying to move your arm and you get like this. So you're trying to move the arm, you've got a combination of a tremor in your hand and the tightness in your arm when you're doing that. So stretching exercises can help to minimize both the tremor and the spasticity. Tremors sometimes will interfere with eating, and so they'll give you an occupational therapist will often give you a weighted uh, implement like a fork or spoon that has some weight to it, and that weight added to the hand helps to stop the tremor.
Hmm, thank you. Amy said that she was diagnosed officially on February 23rd. Excuse me, and she's currently on Kesimpta. She understands that MS is brain and spine related, but she has been having issues with ligaments and tremors tearing. It has happened to my calf, to my toes, and latest my knuckles on my hand. All all I did was flick a fuzzy from my finger and I heard something rip. My knuckle immediately swelled and bruised. My vitamin D levels are good. Have you heard of this symptom before?
This is not common to MS, but it can be common to something like Ehlers-Danlos syndrome, which is often misdiagnosed as MS initially. So you may want to get another opinion as to whether you have MS or whether it's an MS mimicker. Um, and there are very different treatments for those things. If you truly are tearing ligaments and tendons, as your question indicates, um, is has it been diagnosed as an actual torn ligament or tendon by a healthcare professional, such as a physical therapist or your doctor, or is it something that you think has happened? Those would be the questions because that's not common with MS.
Thanks, Sherry. Is dizziness part of MS? Someone's asking.
Can be. It can be. Um, Dizziness has a lot of different causes, and it's a tough symptom to control. There are medications that we use for dizziness when it's a constant thing and really interferes with your quality of life, and usually they don't work all that well. If the dizziness is true vertigo, like you turn your head and all of a sudden the room is just literally spinning, that's vertigo. That's not dizziness. Dizziness would be you stand up too quickly and you get lightheaded. So a lot of people will say that they're dizzy when they actually have that room spinning vertigo. If it's a room spinning sort of sensation that you're getting, you probably have some crystals in your inner ears that have settled in the wrong places, and a physical therapist can take care of that by doing um, uh, rehab moves. There's a maneuver that they use with your head, and it takes about 45 minutes to go through this maneuver to reposition those ear crystals. But if it's dizziness, actual dizziness that you get lightheaded when you have a position change, and not a room spinning sensation, then hydration certainly is something I would look at right off the bat. I would also question whether your blood pressure was a little bit low.
Hmm, thank you. Dina is asking if you recommend spinal MRIs in everyone with MS because she's been diagnosed since 2022 and only had brain MRIs, no issues with ambulation either.
Okay. The recommendation for diagnosis is brain, cervical spine, and thoracic spine MRIs. Beyond that, you should not need more than a brain MRI annually. I know that Dr. Boster did mention the other night that every other year he gets a cervical spine, but he doesn't get the thoracic spine after that initial one. So he'll do brain every year and brain and cervical every other year. Um, I had been diagnosed for, I think, 15 or 20 years, and I went for a second opinion. And since I hadn't had a brain MRI in a year, he did all three. This second opinion that I had did all three. And I said, but I don't have any problems in those areas. And he said, when I bring a new patient, even one that's been diagnosed before, I always do all three just to get a clear picture of what I'm working with. So if you're staying with the same doctor and you're not having any problems, I don't think it's a thing that's gonna, change the outcome at all. particularly if you're on a good disease modifying therapy. If you're not on a disease modifying therapy, I would definitely ask about getting those MRIs because we want to track and make sure that you're not having more damage happening.
Thank you. What's your opinion on cortisone shots in the knee for osteoarthritis, and how would it affect the MS?
You know, when you're getting cortisone injections, it's becoming systemic. I don't know if the person asking the question is male or female. If it's a female and you're over 50, I would say do not do it. Only because you are really increasing your risk for osteoporotic fractures by using steroids after the age of 50. You're also increasing your risk of teeth breaking or cavities being really bad. Dental problems are huge for those with steroid use over the age of 50, more so in women than in men, but also in men.
Hmm. Sabrina says that she's been getting what feels like a cramp in the arch of her right foot occasionally. Would this be considered to be spasticity?
Yes. Um, my husband does this a lot. He gets Charlie horses in his leg or a cramp in the arch of his foot, and he'll jump up to stretch it out. And his doctor said, David, you're just not drinking enough. 90% of those foot and calf cramps are related to chronic dehydration, and you don't even
Mm.
know you're dehydrated. And since he started really focusing on getting that extra liquid in, they've completely stopped. So might try that.
Interesting. David says that he was diagnosed on October of 24 and is currently on Ocrevus. Baseline MRI was done in February, was reported stable and minimally impacted by MS now. His burning hand symptoms that led to his diagnosis due to an active C2 lesion then has remitted. My question is, what could signs of progression be down the line? Anything that he should actually be looking out for, he should be attentive to?
As long as you're on Ocrevus, you're not likely to progress. So stay the course. Progression looks different in everybody. So whatever your symptoms were initially are just going to get more pronounced if you're progressing. But as far as, we know now that if we get people on these highly effective drugs like Ocrevus right out of the gate, many people never progress beyond that point.
And Cindy's saying that sometimes um, her collarbone hurts. Is that something you know, anything anyone else gets?
I haven't heard of the collarbone getting hurt unless there's a spasticity maybe in the shoulder that's radiating the muscles into the collarbone. We have muscles that connect to the collarbone from both the back of the shoulder and the front of the shoulder. So if those muscles have been strained in any way, you've been carrying something real heavy for a while, that could be a problem. So that's the only thing I can think of, that it would be just a strain of the muscles that are attached to the collarbone.
Hmm. What dosage is most effective for tizandine for spasticity?
It depends on the individual. There are times when I first started taking tizanidine, 2 milligrams of tizanidine would have me sleepy. But then I was taking a couple of other medications that also had that side effect, and I have a feeling they were kind of piling on top of each other. If tizanidine is the only medicine, it may be that you can tolerate a higher dose. The tablets come in 4 milligram tablets, but they've got a score that goes both ways. So you can break the tablet into quarters to get as little as a 1 milligram dose. You can safely take up to 12 milligrams as a suggested dose if you need it, and that would probably only be at bedtime. But go with what your doctor's recommending to start with, and ask them to give you a dose range so you can experiment with that to see what works best for you.
Thank you. And Eliza, I'm sorry if I'm pronouncing your name wrong, has her hand raised. So I'm going to go ahead and let's see. I'm going to go ahead and allow you to talk, Eliza. You're welcome to ask Cherie your question. Hmm.
Can you unmute yourself, Eliza?
Let's see. I'm going to go ahead. I just asked for you to unmute yourself if you can hear us. Hmm. She said
Sorry,
sorry she
cannot
can't
talk.
talk.
All
Okay.
right. So
Okay.
can you lower her hand then, Deb? And
Yep.
we'll move on to Karen's question.
Okay. Let's see. Why is it? Let's see.
All right,
I don't think that's working.
Karen's asking if people on B-cell therapies have issues with skin cancer. Um, she's been on Kesimpta for almost 5 years and currently has some lesions that look like basal cell carcinoma, seeing my dermatologist this afternoon. I'm not aware of skin cancer associated with the B-cell therapies, but keep in mind that skin cancers take 40 to 50 years to develop. So if you got a bad sunburn as a child, that's where these lesions are coming from now, 40, 50 years later. So it really does take that long for a skin cancer to develop.
Okay. It has not been diagnosed as I suffer in silence. This is from Amy, and it eventually gets better. What was that name you said that sometimes mimics MS when I was diagnosed twice, and there were lesions in my brain and spine, and also a spinal tap, which had the bands significant with MS?
Yeah, that also is often found with Ehlers-Danlos syndrome. That's Ehlers-Danlos or DANLOS syndrome, or it's also known as EDS.
Okay. Let's see. Let's go to a
Hey,
chat.
Eliza says, can I ask now, please? It's important. Thank you.
Okay.
So, Eliza,
Let's
can you unmute yourself?
let me go over to the attendees. She's not, her hand isn't up. So,
Okay.
Eliza, you have to put your hand up for me to unmute you. There she
There it goes.
goes. Okay. Go ahead. There
Go
you
ahead,
go.
Eliza.
You're on, Eliza.
Do you have your microphone muted, Eliza? Oh, she does now. Oh, you just remuted yourself. Try now.
Hello.
Yes.
Hello. I'm sorry, it's actually my wife who came to the meeting, but I'm her husband and actually diagnosed. It doesn't matter really. What I wanted to ask is about those needle sensations in my fingertip. So basically, I was diagnosed like almost 2 years ago. I had a flare up and I went to the hospital. Had my whole left part of my body was like with numbness sensation. So I had got this solumedrol therapy, I got MRI scans, got everything, got the medication, Tecfidera, because I didn't have any lesions in my spine or even neck. Everything is in the head. So 2 weeks ago, I woke up and had those needles in my fingertips, as I told, but they were almost all day, and they disappeared on the next day only. But after that, I had like this weakness, muscle weakness in my right arm and lower right leg part of my body. So basically, I didn't have this before, but it was like not so as an extreme numbness sensation as I had like 2 years ago. So my question is, I went to my neurologist, and she suggested that maybe I have a new lesion in my maybe neck or spine. That's why I got those sensations of like tired right part of my body. So she suggested to go for this Solumedrol. I just wanted to know whether you think it's an actual flare up and should it be treated as with like this steroid therapy or not?
So you've
Because
been on the Tecfidera now for 3 years?
2 years.
2 years. And when was your last MRI?
It was in January, and I had remyelinization happening and no new lesions.
Okay.
So
I, I would be really concerned that there is, as she said, a potential lesion in your cervical spine, because of the symptoms in your hands. We can't always see the lesions well when they're in the cervical spine. There's so much bone in the area around it. Our spinal cord is very, very tiny in that space, and it's really difficult in some views to see that. And so a cervical spine lesion could have been missed at the time of diagnosis. And if you haven't had another cervical film done, you
well,
might.
I had the first one when I got my first flare up 2 years ago, and
Mhm.
after that I made it was in November 2023, and December 2024 I got the second one, which was also clear. So from that time, how many months have passed? 7 maybe, yeah. And well, actually, I had maybe a few 1 day sensations of tiredness in my right leg before that, but this time it lasted for 5 or maybe 6 days. So I've decided I have to go to a checkup, and then yeah. So your opinion is that there is a possibility that something new could have happened in this seven
Yeah.
month period.
And when you're on a drug like Tecfidera, which is a medium range effective drug, it's not one of the more effective drugs that we have today. Uh, it might warrant going to something a little bit more effective. So I don't know if the Tecfidera was, if you just said to the doctor, I prefer to be on something that I can take by mouth, instead of an injection or an infusion. That may have been why that drug was suggested. But if you've got breakthrough symptoms when you're on one of the oral medications, we generally want to get another MRI and just really have a discussion about putting you on something a little bit more effective. We don't want to see breakthrough symptoms.
Yeah, she actually, my neurologist, she suggested me to go to Clebrazine. I don't know how it's
Cladribine,
correctly. Yes, yes.
Cladribine, that is also known as Mazent. That's an oral medication, and here in the US, we take a total of 4 weeks of that medication over the course of 2 years, and then no more medication beyond that. Um, so I know in parts of Europe, they'll allow you to take it beyond that 2 year period. But in the US, we only do a 2 year treatment course. So you take 5 days worth of pills, and then a month later you take another 5 days. And then a year later you repeat that process. So you take 5 days of a pill, and a month later you take your last 5 day course of the medicine. And if you have, particularly we're using this in older individuals now to get them off of some of the more high efficacy drugs. And it really is the most effective of all of the oral medications that we have.
Okay. Thank
Okay.
you. Thank you for
Thanks
You're
for your
welcome.
question.
answers. Thank you.
Thank you. Um, can you explain spasticity more in depth? This person doesn't know if they're experiencing spasticity or something else. They're experiencing legs jumping while they're laying down, and tightness and weakness when standing, and tripping when walking. Do you
You
have
have
any?
spasticity. Those are all symptoms of spasticity.
Okay.
And a physical therapist can really help you develop a tailored program to your individual spasticity and how it's impacting you. So there's no one size fits all to treat that.
Thank you. LaShawn asks, can a patient go back to a previous medication that seemed to work well in the past? Because they personally were diagnosed in 2005, then was changed to Tecfidera, then to Tysabri after having her daughter, um, then again, they started back to working in the school system and then went back to Kesimpta. So I'm a 41-year-old African American woman who was diagnosed at 21.
There's absolutely nothing wrong with changing to a medication that you were on before that you felt worked well for you. As long as it's an effective medication. And I would say if you've been on Kesimpta and you've been on Tecfidera and Tysabri, um, the least effective of those is Tecfidera. So I don't know if you're thinking about doing that because because it's more convenient taking a pill. So that's all I can say is that I have gone back to less effective medicines that have worked for me in the past, um, and ultimately had moved back to the ones that were more effective. But have the discussion with your doctor and see what they say.
Thank you. We have a 67-year-old female that has secondary progressive MS, and that's active. Is Ocrevus generally not as effective as with someone younger with relapsing MS?
Ocrevus is effective at stopping lesions. It's not very effective at, it's not for secondary progressive MS, unless you're having new lesions on the MRI. You did say that your MS is active. I don't know if it's active because there are new lesions on the MRI or if it's because your symptoms are getting worse. That does not mean that your MS is active if your symptoms are getting worse and there's no change on the MRI. And Ocrevus is not for that form of MS. Fortunately, with the tolobrutinib getting ready to come to market, we believe, probably by the end of this year, we will finally have something to treat secondary progressive MS that doesn't have new lesions.
Nice. Um, we have somebody who's Leslie who says she's currently on Tysabri, but she wants to switch to Mavenclad. Is there a waiting period between starting new meds?
No, no, there's not. In fact, Dr. Boster addressed this last week in his Q&A. I'm sorry. Probably spam, it says. Dr. Boster addressed this in his Q&A last week. And oh, gee, I got distracted with the phone. What was the question again? Tysabri going to Mavenclad, is there a waiting period? He said the sooner he can get somebody on a new medicine, if they're switching meds, the better. He said, in fact, I generally, if I'm taking somebody off of Tysabri and putting them onto Ocrevus or Mavenclad, I will start them at week 2 or 3 after their infusion.
Okay. Let's see. From Bavia to everybody. I don't know if everyone sees this. There's a whoops. Bavia, I
Oh,
lost it. Hold
all
on.
right. Now you have to go into the chat.
There we
Let's
go.
see.
I got
From
it.
Maria, have you heard about the Bioness L300 and what are your thoughts for foot drop due to MS? Yes, the Bioness is good. There are several devices of that nature. They're very expensive though. They're like $3,000 or $4,000 and insurance does not cover most of it. The same with the Psionic Neural Sleeve. And then there's the walk aid. They're all very similarly priced between $3,000 and $6,000, and insurance does not cover the full cost of them. But
Mm.
yes, they are helpful to most people.
And Karen wants to know if people notice a hard time holding their urine at night while they're taking baclofen.
The baclofen is not what's doing it. It's basically you've had too much to drink before bed, or you've maybe started getting a hyperactive bladder, or maybe you've got a low-grade urinary tract infection that's irritating your bladder. So I would get a workup for at least a urinary tract infection and treat that if that's what's going on. And certainly limit your fluids before bedtime for the 2 to 3 hours before bed. And if you've got bedtime medicines, just take a sip of water to get them down and not a glass of water.
Great information. Right this second, you've answered every single question there. I'm sure there's more coming, but as of right this second, you answered. Anything you think it's important for us to tell everybody?
Hmm.
Anything from the consortium that you thought was interesting?
We are looking at some changes to our diagnostic criteria. They were announced last year and never got written up. I'm understanding that they've gone back to the editors several times for clarification, but there are some new MRI findings that are being added to the diagnostic criteria. So that hopefully we can get people diagnosed earlier and onto medications earlier. They're now letting us use the optic nerve. So if you've had optic neuritis and there are lesions on the optic nerve, or the optic disc is pale and retracted when they look at your eye through the ophthalmoscope, those are potential uses. They're allowing us to use OCT, which is optical computerized tomography. So it's like a CT scan of your eye that can be done non-invasively in the eye doctor's office. There are a couple of new lesions that we are finding are that we're seeing on some of the 3 Tesla MRIs. We now know that MS lesions often have a ring around them. And when we look really closely at those rings, they're iron deposits that circle the lesion. And so that's from a breakdown of red blood cells when the inflammatory process hits that causes the lesion. So paramagnetic rim lesions, or PRLs, PR, paramagnetic rim lesions, PRL. They've been calling them pearls. Um, are are a new finding and a central vein sign. Many MS lesions have a little tiny vein coming up in the middle of them. The reason these have not been utilized yet is that only one of the MRI companies has updated their software so that we can see those things. So we're waiting for all of the MRI companies to get their software updated. So those things
Wow.
will help, hopefully.
Super interesting. Vera wants to know if, well, she saw an article stating that a nasal spray for a lumad for
Or
a
a
lumab
Lumab.
can help with MS. Have you heard anything about that study?
It's not ready for prime time. You won't be seeing it soon.
Okay, good enough. Dennis says, how can I be more confident in understanding relapse versus something else? For example, I had a hot foot sensation, which was new, but it didn't last 24 hours. It was intermittent for a few days. My MS neuro believes it could have been plantar fasciitis or a metatarsal, I can't even pronounce it,
Tarsal.
metatarsal. Nonetheless, I panicked. Could a relapse last a day? Could the altered sensations be intermittent?
No, no to both.
Okay, that was easy enough. Have you heard kidney stones causing issues with MS?
Some people are really hypersensitive to vitamin D, and the higher dose vitamin D can cause kidney stones in people that are sensitive to that. So some people are having to either drop their dose of vitamin D to a lower level or actually um, get rid of their vitamin D altogether if they're having kidney stones.
Thank you. And Trisha, what a sweet thing to say. She wants you to know that she's proud of you, Cherie, for all the help you are to those with MS. Yes, we love her.
Disclosure, Trisha is my sister.
It doesn't matter. It doesn't matter. She's proud of you. How
Well,
nice.
thank you.
How nice.
Thank you.
Sabrina says that she's been having some numbness that comes and goes in her right leg ever since it's been in the high 90s and very high humidity here in Tennessee. I haven't had any numbness since first being diagnosed last year. Could this just be heat related? She only goes out in the heat if absolutely necessary because the heat really does cause a problem for her. It drains her. Drains me too. I don't even have
Yeah.
MS, so I can only imagine.
Yeah, Sabrina, I literally am a hermit in my house during this time of year. I can get out briefly for maybe an hour or so with cooling vests and scarves and hats and things like that on to keep me cooler. But yeah, the numbness, the fatigue, the brain fog, vision in my left eye all get worse when I get overheated. So yeah, be kind to yourself and hydrate well and stay in.
Stay inside. My goodness, and it doesn't matter where you are, it's still hot. Okay, so this person says that they've had MS for 34 years and now they're 60 years old. They've had progression in their mobility, 6.5 EDSS equals 7. I have heard that MS slows down when you're over 60. Is that true or not?
It tends to be true. If your EDSS is getting worse, if you're actually progressing, my guess is that you're not on an MS medication right now. And certainly if you're having this kind of progression at 60, that's still pretty young. Um, I would if you haven't had an MRI in the last year, I would certainly ask to have one done. It could be you've got new disease activity. Many women, as they enter menopause, are actually getting new lesion activity. We think estrogen is neuroprotective, and as we begin to lose that estrogen, we do have some increase in disease activity in some women. So it does warrant another MRI.
Thank you. Karen said that in her last MRI, it was positive for T1 hypointense lesions with no quantity. Should she ask how many? Does this imply loss of brain volume? Cherie, you're a rock star, and I'm not your sister.
Thank you, Karen. Um, oh, it doesn't really matter how many lesions there are. It's not the quantity, it's the quality. If it's hypointense, hyperintense, those just give a quality to the doctor to let them know that there is a change from the last MRI. The changes are what are important. With those changes, we may need to discuss a treatment change. So it does not imply a loss of brain volume. Many MRIs are now quantifying brain volume with a percentile. And so they'll say that the brain volume is in the 90th percentile, meaning that 10% of people have more brain volume than you do. But you know, if they haven't stated a loss of brain volume, I wouldn't worry about that. And thank you for the compliment.
Let's see, experiencing extra stiffness in legs, do I need to up my dosage of tizanidine? I'm in my late 60s and female.
Okay. I would certainly run that by your doctor. And again, as we talked about tizanidine a few minutes ago with somebody else asking the correct dose, you need to get a dose range from your doctor that they're comfortable letting you stay within. As I said before, 2 milligrams at one point was almost too much for me. And I'd get up to 6 milligrams and I'd be seeing Disney-esque colorful flying bugs on the ceiling. So it's totally a personal thing as to how the drug impacts you. Um, 12 milligrams might be a safe dose for some people, and 2 milligrams might be a safe dose for another.
Thank you. Lashun wants to know, can someone receive physical therapy at home instead of going into a hospital or a facility?
Well, you can get physical therapy in an office. Physical therapy in the home, if you're homebound, yes. Most insurances, if you're homebound, will pay for physical therapy for a limited time in your home.
Okay. Um, oh, let's see. I don't know if we answered this one. Uh, Karen says 68 and been off of Ocrevus 3 years and no drugs. Currently thinking about going on Mavenclad. Thought it was a UTI causing worsening, but now thinking it is MS flaring again. My MRIs never show much for last 28 years. Now foot drop in both feet, very challenging. What are your thoughts?
If you've been off medication for 3 years and you're 68, you may not find somebody that's willing to put you on Mavenclad at this point. It's often a drug that we use um, as a step down drug or a final drug when we're taking somebody off of a medication like Ocrevus. It does seem to have about 15 years of data now that show that there's no progression in 95% of the people that have taken that 2 year course of Mavenclad. Have the conversation with your doctor. Your doctor has been working with you, they know you, and they may very well be open to that. But with the 3 year gap in medicine, it might not be something that they'd be willing to go with.
Thank you. Out of curiosity, why no lumbar MRIs? What does it mean when your neurologist recommends a lumbar MRI?
All right, so the lumbar MRI would be recommended if they thought you had a disc problem that was causing low back pain or pain radiating down your legs. So that would be done more to determine if you needed a surgical intervention or even if you need a specific protocol with a physical therapist to deal with a degenerative disc disease or you had osteoporosis of the lumbar vertebra.
Thank you. Do you have any recommendations for Christina, who says that she's having difficulty eating due to dysphagia?
Yes, a speech therapy consult. They work with people who are dysphagic or who have swallowing problems. Um, if you go to our webpage, msfocus.org, and you search for swallowing difficulties, we have several articles that explain what happens that makes it difficult for you to swallow or difficult for you to speak or um, things like that that can be addressed with a speech therapy consult. I would recommend that.
Thank you. And this person, although they said LOL at the end, I'm sure they were serious, took a fall and landed on their right breast. Is there anything that she can damage with that part of the body?
Well, it's well padded. So you could break a rib. I did that last year. I was at a conference and walking across the street and caught my toe on the curb cut as we were crossing in the crosswalk. I was talking to somebody and looking over this way and thought I was in the crosswalk on level ground, and my toe caught as the curb was just starting to come up, and I landed flat on my chest, and I broke 3 ribs. So if there's continued pain, there's really not much you can do for a broken rib, but if you're having trouble breathing, that needs to be assessed right away. Otherwise, it may take a few weeks to kind of manage that, and you may have some bruising. I would say ice for the first few days and then heat to help reabsorb any bruising.
Hmm, good answer. We have a few more minutes. If anybody has a couple questions, we're happy to answer those. Um, Cherie, do you have anything last minute you want to mention?
Let's see. Hormones are all over the place in the news now. We are hearing, in fact, 1A on NPR this morning talked about the role of hormones in all kinds of conditions with women going through perimenopause and menopause, and how it seems to really hit women with autoimmune disorders even harder and make their disease worse. And so they're recommending that any woman who's starting to have symptoms of menstrual irregularity or hot flashes or joint pain. Joint pain is emerging as a premium symptom of people starting to go through perimenopause. That you have the talk with your primary care doctor or your OBGYN about doing some hormone replacement therapies. And blood tests aren't going to tell you if you're still menstruating. Blood tests aren't going to tell you if you're perimenopausal because they change continually throughout the cycle. So you really need to test at the same time in your cycle. If your FSH or follicle stimulating hormone is elevated, if you do have a blood test, it generally means you've stopped ovulating. And if your estrogen is really low at the same time that FSH, follicle stimulating hormone, is up, that can be an indicator that you are already in the menopausal period.
Thank you.
So
Can you tell Karen, she's asking if there's a cutoff age for Mavenclad, an age upon which it becomes too dangerous to take it?
I don't know that there is. I think it's more based on whether or not there's actual disease activity present when you do an MRI, not on progression. Mavenclad doesn't really slow progression. So it does keep new disease activity from happening. I'll be 73 in a couple of months, and I just finished in May. I finished my second year of Mavenclad. So I'm much older than you are, Karen. I say much older. Um, you're only 68, right?
A
Uh,
baby.
a baby. So I don't know that there is a cutoff. I think it's more, they probably wouldn't start you. Oh, 66. I'm sorry, Karen. Somebody else said that they were 68. Uh, you're right in that perfect time to have the conversation with your doctor, Karen. 66 is a good age to have that conversation as to whether or not to switch.
Cherie, I have a question.
Yes, ma'am.
My doctor, because we were talking about hormones, um, I don't eat meat, so traditionally I was eating soy products. Soy, she says, is something that mimics estrogen in your body.
Progesterone. Progesterone.
Oh, she told me
It's
estrogen. She said it's
no, it's
estrogenic.
yeah, it's progesteronic. So progesterone is the other female hormone. Estrogen and progesterone are the two that they usually use to supplement when you have hormone replacement therapy. If you still have a uterus and it's functioning, you want progesterone on board, um,
Interesting.
along with the estrogen. Tofu, things like that have that. Mexican wild yam has a progesterone-like impact. So
And she said alcohol also produces that in your body. It was an interesting, fun fact. Yeah.
well, alcohol can also accentuate the vasomotor symptoms, the hot flashes. So if you're
Oh.
having hot flashes, I don't recommend that you imbibe too much.
Hmm, interesting. Okay, well, you've been thanked a million times here today. You've been blessed. And people absolutely love you, Cherie. We're so excited that you do this for us. Every other month, this is what she does. Let's, I, oh, you're still getting thank yous and rock stars and rock stars. We do. Well, we love you. So why don't we, um, why don't we call it a day? Because we're at the top of the hour. And Cherie, we really appreciate it. That does bring us to the end of our time. If you've missed any part of this conference, it has been recorded and will be available through the MS Focus Facebook and YouTube channels. You can reply to your registration email for information on how to access these recordings, or you can even sign up for our newsletter, which is going to teach you about the upcoming events. Our next teleconference is going to be Tuesday the 8th at 4:30, at which time Dr. Ben Thrower is going to once again be answering his MS-related medical questions for an entire hour. So if you think of anything between now and the next time Cherie speaks, you have an opportunity to actually have that answered by either Dr. Thrower or Dr. Aaron Boster. Every other month they do that. So as you leave the conference today, a survey will appear on your screen. We ask that you please take a moment to give us your feedback on this program and your suggestions for future topics so that we can be sure to provide you with the most meaningful programs possible. Our sincere thanks to all of our attendees today and for your participation, and especially to Cherie. Cherie, I know you spend lots of time helping the Multiple Sclerosis Foundation and the MS community. We're ever so grateful for that. Enjoy the rest of your day, everyone, and we really look forward to seeing you next time. Have a good night.